Hello, everyone. Thanks for joining us today. I'm Amanda Glassman. I'm Executive Vice President and Senior Fellow here at the Center for Global Development. We're really pleased to welcome you to today's seminar on the launch of a new and important systematic review and meta-analysis paper by Michael Kramer, Stephen Luby, Ricardo Martins, and Brandon Tan that looks at water quality and access to higher quality water and child mortality. As we know, obviously, safe water is really a core development intervention, but it still remains a huge challenge in too many parts of the world. More than 2 billion people are estimated to still be drinking contaminated water, and about 1.5 million people are dying each year from diarrhea. So today we'll discuss some innovative evidence about the cost effectiveness of water treatment for child survival and the role of chlorine dispensers and water treatment within broader public investments in infrastructure and healthy environments. And I should say this event also links to an ongoing Center for Global Development working group that is focused on how impact evaluations and evidence of rigorous impact should inform public policy making more. And so I'm really pleased that the authors were interested in presenting on our platform and really reflecting on what it all means for policy and the use of government resources as well as aid and philanthropy. So we'll kick off today with a presentation from Michael Kramer, who's the University Professor in Economics and Director of the New Development Innovation Lab at the University of Chicago, and of course, the recipient of the 2019 Nobel Prize in Economics, and not his most important affiliation, but he is also a distinguished non-resident fellow here at CGD. And he's accompanied by his co-author, Stephen Luby, who's the Professor of Medicine, Infectious Diseases, and a senior fellow at the Woods Institute at Stanford University. After the initial presentation, we'll be joined by two discussants. First, Dr. Patrick Amos, who's the Acting Director General for Health from the Ministry of Health in Kenya and President of the Executive Board of the World Health Organization for Africa region. And Dr. Pascaline Dupas, who is a professor of economics also at Stanford University and the faculty director at the Stanford King Center for Global Development. So we're really pleased to get started. I'll turn it right over to you, Michael and Steve. Thanks.
Well, I'll go ahead and get started. And I just want to thank you very much, Amanda, for hosting us. And I really want to thank our discussants, Patrick and Pascaline, for giving us your time and your input on this. We are going to discuss a meta-analysis that we've been working on for quite some time, co-authored, really led by Michael Kramer, and co-authored by Ricardo Martins and Brendan Tan, who's now in IMF Research Department, on this meta-analysis of water treatment on child mortality. Both Michael and I will present, and I want to characterize that although, yes, it was published today or made available today, we still consider this very much a work in progress and really are very open to feedback. Most broadly, we will argue that the impact of water treatment on child survival may be very large. Michael will then discuss some delivery mechanisms for water treatment and cost effectiveness, bringing in insights from some papers with other social scientists, including Pascaline, who's here today. So next slide, please. And next slide. Oh, no, that's it. I'm sorry. Back up. So I'm a physician here, so I'll make the point that we all need to drink water. Water is necessary for survival. The problem is that about 2 billion people consume drinking water that's contaminated with feces. And much of this feces has pathogens in it. Those pathogens make people sick. Most commonly, they make young children quite sick with diarrhea and can kill them. Now, water treatment, even using dilute chlorine, which is basically similar to chlorine bleach in the home, is a technology that's been used for over a century. It's widespread and it's effective against most, not all organisms. There are some chlorine-resistant organisms, but it's pretty good. It covers most of them. It's inexpensive and it's quite safe. We have consistent evidence that water treatment reduces reported childhood diarrhea. There have been lots of randomized control trials on this and a couple of big meta-analyses, and that's a pretty well accepted impact of treating water treatment. But experimentally measuring child mortality requires really large sample sizes. And for low-cost water treatment, there's very limited commercial interest in funding these large studies. And so the studies of water treatment interventions have characteristically been powered for caregiver-observed diarrhea. This means then that we don't have the kind of rigorous data on treatment of water on mortality, and so water treatment is often not included in lists of evidence-backed child mortality interventions. Next slide, please. So we decided to do a meta-analysis. And I would say that the meta-analysis doesn't exist in isolation. If we go back to the early 20th century, we know that cities that implemented improved water treatment had reduced mortality, but we don't have really contemporary, high-quality, randomized control trials with a contemporaneous control group. So next slide. We began by looking at the data that was out there and that was available. We looked at the prior meta-analyses looking at water treatment and diarrhea and identified 73 studies. We then looked at those search criteria and applied them more generally and identified another 1,412 studies. This then generated titles and abstracts to review, which were reviewed by 2 people, all 1,485. And then among those that met our criteria, we contacted authors to find data on all-cause mortality. And this is important because mortality is a rare outcome and so often wasn't included in the papers. Next slide. So if we look at what we found, ultimately, by reviewing all those titles and abstracts, there were 82 studies that we reviewed the full papers on. 63 of these were studies conducted in lower middle income countries. 53 of those were randomized control trial, 52 included children under 5. And of those, 80% of the authors, 42 responded. 19 of those had collected mortality data. 17 of them still had that mortality data available. And in 15, there was a pure control group that hadn't been contaminated with other interventions. So next slide. Yeah, the next click. Yeah. So if you look at those 15 studies that had a good control group, 12 of these were for chlorination, 2 of them were filtration, and 1 was a spring protection study. So the bulk of this work has really been around low-cost chlorination. And if you look at these studies, they run from 1970 to 2021. So these are studies that were conducted over the last 50 years with a rigorous contemporaneous control group. Next slide, please. So one of the things we worry about is if you started with 82 studies and then you get down to 15, well, how well do these represent the broader experience with these interventions? So this is a histogram that shows the proportion of people who had diarrhea in these studies in the largest study, the most recent study of Jennifer Wolf's meta-analysis from 2018. And what you can see is that if we look at where the meta-analysis studies were, they really sit right here within the range of what we found, what Jennifer Wolf reported in the larger meta-analysis, and the median is really quite close to the median from those larger studies. So it looks like this subset is pretty similar in terms of the amount of diarrhea. And similarly, the studies that were included in our analysis have similar compliance, similar units of randomization, similar treatment effects on diarrhea, and the similar levels of diarrhea prevalence. Next slide, please. So if we look here, this is a forest plot of the pedo odds ratio random effects model. So an estimate less than 1 implies a reduction in mortality. And so what you can see here is that the average reduction in mortality, a Peto odds ratio of 0.72, becomes a reduction in mortality then of 28%. If we restrict this analysis to chlorination, these ones here, then this increases to 31%, but it's not quite statistically significant. If rather than using a Peto odds ratio, we use a Bayesian odds ratio, this reduction is 30%. Michael's going to talk a little bit about what the implications are of these numbers for cost effectiveness. But as a public health physician, I just want to step back and call out that this is a big effect. We're talking about something on the order of between 1 in every 3 and 1 in every 4 children who die, under 5 children who die are dying of diarrhea, or are dying of diseases that could be prevented by water treatment. Now, of course, we have to interpret these results carefully. The impact of water treatment is going to vary depending on things like how great the burden of diarrhea is in a given area. However, in our sample, we don't find much evidence for the effect varying among groups. The I-squared was 29% in the Peto odds ratio specification, suggesting that 29% of the variation across the studies was due to underlying variation in the true odds ratios, and 71% was due to sampling variation. We can't reject the hypothesis of a homogeneous effects. I also should point out that there is a fairly wide confidence interval, from 8% to 45%. But even at the low end of the confidence interval, reducing child mortality by 8% would still be a big effect. We've also performed a number of sensitivity analysis and tests for publication bias, and I'm a physician, so I could also expound on biological plausibility, but I won't go into any of that now, but we're happy to answer questions on those. So I want to turn this over to the next slide to Michael.
Michael, we can't hear you.
Thanks, Steve. I'd love to now discuss different delivery systems for water treatment and also talk about cost effectiveness. So let me just start with a general principle on cost effectiveness. Governments, sometimes there's a focus on what's the single most cost-effective way of delivering something. And in general, governments may not want to focus on only the most cost-effective method available, in particular because water treatment, and I'll be quantitative about this later, because water treatment is so cheap compared to lots of other interventions. It makes sense to use not just the cheapest delivery methods, and somewhat more expensive delivery systems may reach more people and be more cost effective than alternative health programming, and thus may increase the total health impact of a ministry budget. So I'll be more concrete about this as we go on, but let me start with something that has something that's one approach to delivery, which is which is already out there and which is just reaching a very small fraction of the population, but is very inexpensive in terms of physical cost. Maybe we could go to the next slide. So one approach is to socially market water treatment. Small bottles of dilute chlorine solution are sold, and treatment take-up rates of that vary. But in a couple of studies that we cite below, we found take-up of 4%, 7%, or others in other contexts found 7%. There are some cases where it gets significantly higher, but it's quite modest. Now, one result that is robust across a range of, this really comes from behavioral science, that actually, I think Pascaline would differ with that, and she has a very good argument. So let me not say for sure it comes from behavioral science. That's one interpretation. It could just be people just don't have much money. In any case, whatever the reason, free provision seems to substantially increase take-up in a variety of contexts. So if you go back to the 1990s, many policymakers, many NGOs advocated user fees, but we now have experiments across a wide range of areas suggesting that there's a very large response to a very large difference on take-up between charging a fee or providing things for free. So for example, a small fee for deworming treatment reduced take-up from 70% to 17%. Work that Pascaline's done with Jessica Cohen found huge reduction in purchases of mosquito nets when there was a charge, and didn't find that the fee was a good targeting mechanism. And in the case of water treatment, some work that Pascaline and I and Alex Wane were involved in, we found, which I'll share in a more detail in a minute. We found the fee reduced take-up from 34% to 12%. So you might want to consider free treatment. Obviously, that will be more expensive for the government, not for society as a whole necessarily. There might be some concern that this would lead to wastage. So let me discuss a project that on the next slide that with Pascaline, Vivian Hoffman, and Alex Wane, if we looked at a program that provided coupons for free water treatment solution that were distributed and could be redeemed at clinics, and that could be redeemed at local shops or clinics. What we found was that this led to usage that was almost identical to free delivery, but and this was distributed just to households with young children, so it targeted the right population. And we saw that there was very little wastage of this. The households that obtained the water treatment solution, so this is one particular brand that you're seeing, WaterGuard, were very likely to use it. We tested their water to see whether it was treated with chlorine. I think one huge advantage of this approach is that it's very easily integrated into existing health systems. So when most mothers are coming in to visit clinics for delivery, for postnatal visits, for immunization visits, and the coupons can be handed out during those visits. And then they can pick up the water treatment solution either at the clinic itself or at shops. Because this is socially marketed, it's often available at shops in many countries. So I'll come back to this later, but I think it can be an extremely cost-effective approach. The earlier study that I was involved in tested this at quite small scale. Pascaline now has new work in Malawi doing this at larger scale and finding very similar results and demonstrating some health impact. Maybe we could go on to the next slide. Another approach, well, actually, let's go back 1 second. So what we found is about 1/3 of people using, so a substantial gain relative to just social marketing where households have to pay. And when I was making the general comment earlier, some cases it's worth paying to a bit more to get higher uptake of something that's as cost effective as in reducing mortality as we found water treatment to be. This is I'll show some cost effectiveness numbers, but I think this is one case where it would be. Let me go on to something that would take usage levels even higher, but is a bit harder to deliver and can only be delivered in certain situations. And maybe we can go on to the next slide now. This is water treatment dispensers. This is something else that I've also been involved in for disclosure. So these dispensers are placed at a water collection point, and they have a valve that releases the correct dose of chlorine solution for say a 20-liter jerry can. And they're designed using some principles from behavioral science. They're free, which I argued is important. That could be from behavioral science, but also from other areas. They're very salient. They're big, bright blue. They're convenient. They're right there at the water point. There's a time each day, when you're collecting water, that you would treat the water, and that's useful for building habits. And they're public, which means that people can see other people using them. They can ask questions. People can see whether they're using them, which might help build a norm. And so in an initial study of this, we found 50% take-up sustained after 2 years. This has now been, that was sort of an early version of this. An NGO called Evidence Action has now scaled this up and refined methods. There are currently 4.4 million people who have access to this, and 2.5 million people seem to use it on a given day when they do testing to see if people have chlorine in their water. It's 2.5 million people who seem to be using this. Now, what are some limitations of this? Well, first, it's only cost effective when enough households share a water collection point. If there's a single household installing a dispenser, that would involve some extra cost, and maybe that wouldn't be worth it. So if this is a non-point source, if people are just collecting along a stream anywhere, maybe this wouldn't work. It also requires some infrastructure to be built, maintained, refilled. Evidence Action has done that successfully, but it's not that every government already has a system in place to do this, the way that almost every government has a network of clinics and maternal and child health services. Okay, maybe we could go to the next slide. If we continue to ascend the ladder to get higher take-up, I'll go back to the previous slide. This 50% take-up, this is roughly 4 times the level that you would get from just socially marketing water treatment solutions. So we're getting from single-digit take-up to a third to a half. We want to go even higher. One approach that can work, and maybe here we could go to the next slide again, is inline chlorination. So this does require a pipe, but if there's a pipe, you can attach a device that delivers a fairly low dose, so that addresses taste barriers. And I think there's variation around the world in whether people object to the taste of chlorine, but certainly there's some parts of the world where a lot of people do. And so the taste can be a major advantage of this. The devices are fairly cheap. There's an RCT, again, suggesting health impacts of this particular method, but I think the basic logic of the science is that delivery of chlorination should be treating water similarly most places, just independent of the delivery method. This does need infrastructure, and in fact, it requires water to come through pipes. So there's some types of sources where the water doesn't come through a pipe, and there'd be some additional costs involved in this. So in some circumstances, let me just mention one further or a couple of further things that you could go in this direction. Obviously, large parts of the world have water delivered through municipal water treatment systems. Those are going to be reach a lot of people in the areas where they're suitable, but those are going to be more expensive in, say, rural areas where people live on their own farms rather than living centrally all together in a village. So that's going to be still more expensive. So I think my overall view would be that it's not that we want to choose one of these methods, that we probably want a combination of these methods depending on the circumstances. And there are some methods that could be done everywhere, or virtually everywhere, like the coupon approach. There are other methods that, like municipal water chlorination, which we hope eventually at higher levels of economic development, everybody will get, but for the time being may only be possible in some areas. Let me go to some numbers though, and look at cost effectiveness on the next slide. So let me start with the Evidence Action Dispensers for Safe Water program. Here we're using real data that Evidence Action's provided on their costs and the number of people reached and on usage. Then we did some more back of the envelope hypothetical calculations for a coupons program. There, we don't have data from the implementation at the same scale that of reaching millions of people, but we've made some rough assumptions. These would have to be investigated further. But let's assume, for example, that the cost of delivery is just as much as the retail cost of buying WaterGuard in a shop. So you double the cost for that. And some other relatively tough assumptions. We would still get an estimated cost effectiveness that's quite similar to dispensers. There'll be some differences here, but they're extremely minor in the big picture. There's really no appreciable difference. Why don't we go into the next slide? So here are some calculations. I'm going to skip over some of the details, but let me show you the numbers for the cost per death of a child under 5 averted. These would be under $3,000 per death averted. And if you want to express this in terms of disability adjusted life years, they're each about $35 per disability adjusted life year averted. So these are enormously cost effective. They're on the same order of, there are only a small number of health programs that have been estimated to be under $100 per DALY averted. Things like vaccination, anti-malaria bed nets, rotavirus vaccination, some micronutrient interventions. This suggests that water treatment belongs on that list, belongs on those lists. And take this last calculation as with a grain of salt and as a back of the envelope calculation. But WHO estimates that 2.2 billion people around the world don't have access to safely managed drinking water services. If you take the meta-analysis estimate of improved water quality on child mortality, and then you adjust for coupon usage rates, which are only about a third, that suggests that a program that targeted that population would save approximately 500,000 under 5 lives annually at a cost of just under $1 billion per year. I wouldn't take those numbers as authoritative, but I think they give a sense of the order of magnitude and of the potential here. Can we go on to the next slide? So to conclude, the meta-analysis suggests that water treatment is a highly effective and cost-effective way of reducing child mortality, probably up there with the most cost-effective health interventions in the world. As to generalize my point earlier, I don't think it's a contest about which is the best. I think we have sufficient resources to do all of these very cost-effective health approaches. I think different delivery mechanisms will be suitable for different circumstances. For some of these, they've been done at scale, but I think others will need more work to examine exactly the details of how to scale this. And but I think these results suggest that should be a high priority for governments and for philanthropy. Thank you. Oh, let me add one more thing. I think we'll be a few more days before we'll be able to release the working paper for the meta-analysis publicly. We're still making a couple of tweaks to it.
Thanks, Michael and Stephen, and we'll certainly post the paper on the event site when it's released or a link to it. Now let's turn it over to a couple of discussants. We'll start with our colleague Patrick Amos. Come back on video. Here he comes. Hi, Patrick.
Thank you, Professor Kramer and team, for that wonderful presentation of meta-analysis of the data on availability of safe water and reduction in child mortality Indeed, for us coming from the low middle income countries, this is a topic very close to our heart because diarrheal diseases and of course infections, especially pneumonia, are the two leading causes of maternal mortality, and our governments have tried to put interventions in place to be able to address child health. And we know very well if we can be able to address inequities in child survival, then all children living in any place will have a chance to be able to reach their 5th birthday, irrespective of where they live. As a result of that, the government of Kenya has made significant efforts to be able to ensure that maternal child health programs are prioritized. And one of the things we did as a background before I come to specific comments regarding the presentation is one, of course, was removal of user fees for primary healthcare services so that women and children, especially under 5 children, could be able to access services. As a result of that, our infant mortality rate dropped from 74 per 1,000 live births in 2008 to 52 per 1,000 live births in 2014. We were not able to do the Kenya Demographical Survey in 2019 because we conducted a national census and we did not have enough resources to do that jointly. However, I'm glad that today we commenced the exercise to be able to do the Kenya Demographical Survey 2022. And we are going to capture more in terms of child health, including childhood development, which was never captured in the previous Kenya Demographical Surveys. As a country, we are also in the space of rolling out universal health coverage with a strong primary healthcare approach and community-centeredness so that we invest in our people at community level so that we can be able to change their behavior to spur better health and economic prosperity. Of course, Professor and the other speaker talked of other high-impact interventions that we have continued to undertake, including routine immunization. We introduced rotavirus into our routine immunization services in 2013. We have other interventions, including use of ORS and zinc for treatment of diarrhea, and that has also increased. If you compare the figures in 2008, 2014, combined with that is vitamin A supplementation, and of course, we strongly promote breastfeeding because we still have a challenge, of course, especially neonatal mortality rate. And breastfeeding rates have increased from 32% in 2008 and to 61%, almost doubling in 2014 Kenya Demographical Survey. Of course, if you look at Kenya, the western part and the eastern coastal region are high malaria endemic zones, and of course, use of insecticide-treated nets for malaria control. And of course, these are all delivered for free, again, in response to Professor Kremer's remarks of delivery of these services, include in circumstances where you put a fee, then you reduce the uptake, and therefore the government has continued together with development partners to ensure that this is delivered for free. And more specifically now going to the presentation, I think the meta-analysis clearly shows that there's a significant reduction in mortality if we can be able to provide safe drinking water. And this therefore calls for a policy shift so that we can be able to promote that as one of the high impact interventions, even though we know very well water, education, environmental, clean environment and sanitation are also other social determinants of health. But now we have scientific proof that if we invest in clean water through those various combination of methods based on the requirements, especially for us, if you're looking at the informal settlements, the urban informal settlements, which are where huge populations live, municipal water does not reach them, and therefore the dispensers, the coupons could work very, very well to be able to address the issues of safe, potable drinking water. Then what we will be able to do is to, based on the paper that is going to come out, if we can be able to have a policy brief and see how best we can be able now to make this as a standard policy as one of the critical interventions for improved child survival, and how we can be able to scale it up using differential methods based on the needs. What may work well in the urban informal settlement may not work well in a rural setup where populations are much dispersed. And then again, if you look at our population in the northern arid lands where people are mobile, the mobile population, pastoralists moving from one place to other place with pasture, then again, probably the coupons will be able to work very well so that as they move, they can be able to have their water guard so that they can be able to have safe drinking water. So we are very, very excited about this, and we want to thank Professor and team for what they have done in Kenya. And we are quite excited that this will form part of that policy shift based on this emerging evidence that we should be able to quickly run away with so that we can be able to improve the lives of our children. I will pause at that particular point and probably then respond in case there's something specific to me.
Thank you, Dr. Amos. I have many questions for you. And I mean, one question to you is you mentioned primary health care. I mean, were these kinds of chlorine dispensers or that intervention around household controlled chlorinating of water, is that on the list of primary health care services? You know, is there money to procure within the money that's transferred to the county level to provide primary health care? Can you just sort of reflect on that issue? Because one of the points that Professor Kramer was making, of course, is that you know, we need all these things. We need municipal water systems, and while we're waiting for municipal water systems to connect, we need these other kinds of interventions that can deliver clean water. But because of the way that we organize sectoral work, you know, the public works department might be in charge of water and the health sector is in charge of clinical care, and those thoughts might not come together. Can you reflect on how that's worked in Kenya? Is there something to do there as well?
Thank you for that good question, because in Kenya, when we rolled out universal healthcare, following that directive by the president under the Big Four agenda, what we did was to be able to bring other sectors into play, what we call the enablers of achievement of universal healthcare. And water is one of the key enablers of universal healthcare. The other enabler was the Ministry of Public Works, so that we can be able to have internet connectivity, because we are also reforming our national health insurance fund to ensure that we have a seamless claim system. So we are able to do fiber optic connection to the facilities. We are also doing that with the Ministry of Energy to ensure electricity is connected to the facilities. So all of these enabling ministries were also given additional resources to ensure that all this might seamlessly, so that together we can be able to move forward without these enabler ministries. The Ministry of Health will not be able to deliver on its own. So this is factored in the budget. Additional resources was provided for water, for infrastructure in terms of roads, for fiber network connectivity, and for electricity and sewerage connection. So it is something that we have thought about, and we have put it together in the entire basket of primary healthcare, universal healthcare under the primary healthcare approach.
Interesting.
Thank you.
Well, we'll come back to you to ask how that's working, if it's yielding the kinds of investments that you're hoping. Let's now go to Dr. Pascaline Dupas, who has taken a look at this paper and has some thoughts. Go ahead.
Great, thank you very much. Let me just remind everybody of the problem that is facing us. It's very simply the fact that diarrhea disease remains a major cause of death around the world, especially among children in low-income countries. You can see from this graph from our world in data that deaths from diarrheal diseases have gone down in the last 30 years as countries become less poor, are able to invest in large public infrastructure, especially clean municipal water. I was just discussed, but there's still a large chunk of folks around the world who face a big danger from unclean water. And so if we think about the causal pathways through which water treatment, which is what we're talking about today, may affect child morbidity and mortality in particular, it's pretty simple. Okay, if you have contaminated water that children are going to drink, you're going to have children who get contaminated with pathogens, and then that's going to lead to them being sick and often dying. Okay, so when you treat water, the idea is that you're going to get the water to be clean, and then you eliminate this pathway here. So you're going to have, fewer contaminated children and hence a reduced mortality. Now, what has been kind of bothering folks for up to the analysis of today is the fact that there are other factors that contribute to contamination of children, and in particular, there may be other environmental factors besides just the quality of the water and behavioral factors that may mean that children actually are still contaminated, even if they drink clean water, or even if the water that they, at some point becomes clean, but then becomes dirty again before they drink them. And hence maybe you don't have as much of a meaningful reduction in mortality. And so the debate, up to now was really about that. It was, well, we know that contaminated water causes diarrhea. We know that chlorination and other water treatment interventions are going to reduce water contamination. These are just, very clear. But what wasn't clear until today's analysis is whether in low-income settings, it would be enough. Is it enough to reduce children exposure via the water pathway to impact mortality when there could be these other factors at play? Okay. So what I'm hoping to do with this discussion is to shift the debate a little bit and to say, well, even if it may not be sufficient, I want to stress that it is necessary. Okay. And then thanks to the new analysis that Steve and Michael presented, we actually now are in a much better position to say, well, actually, in many cases, it may be sufficient. Okay, but I also want to stress the fact that even if it's not sufficient, we at least know it's very necessary. Okay, and that's just, the science is clear. No, it's very clear that if you drink contaminated water, it's not good for you. Okay, so access to clean water is necessary. You can think of it as being, a fundamental need for people. Okay, so that's number one. Access to clean water is necessary. Now, is it enough? Likely it depends on the context. If you look at historical studies that have been done, there's a study in Mexico that was published recently that looks at a big infrastructure program that was put in place, a large-scale municipal water disinfection program in 1991. The study estimated that it actually led to quite a substantial decline in diarrheal disease deaths among children, about the same magnitude as what Steve and Michael presented today. The estimate was very, very cost effective. Now they do show that, in some, there is some heterogeneity there because access to complementary inputs, especially infrastructure, was heterogeneous. So they show in the paper that degradation of water pipes over time and lack of sanitation infrastructure can attenuate the impact. So it suggests that it may be sufficient in some cases, but often you need enough other things. And that's also consistent with some evidence, historical evidence from the US by Alsan and Goldin, that show that safe water system and effective sewage were complements in contributing to the initial decline in child mortality in US cities at the turn of the 20th century. Now, this adds to some mixed results from previous meta-analysis that suggested that complementarities may be very important in low-income context too. So what we learned today from the presentation and the new results by Steve and Michael is that actually, when you look at enough sample, we have enough sample size to really look at mortality carefully, it may actually be sufficient on average. Okay. And in fact, one of the very important results of that study is that they cannot reject homogeneity, okay? Which means that, it's not only sufficient on average. In expectation, if you do this program, you're going to find a positive effect and a reduction in mortality, but also they cannot reduce that it's going to be there everywhere. And so the key question then becomes about the cost effectiveness. And so, using the average cost observed in Kenya, what the study estimates is that it's very highly cost effective to do this. And as Michael mentioned, either a coupon version or a dispenser version of the program could save approximately 500,000 under 5 lives at a cost of just under 1 billion each year. Okay, so just to make this very concrete, if there's somebody out there who has 6 billion to spare, then a 6-year water treatment program could save 3 million children's lives. Okay, I wish I were that person. Hopefully some of them will somehow see this video at some point. I have full faith in the CGD's network. Now, I want to stress that these cost effectiveness figures are so mind-blowing that even in areas where the cost may be higher, may say because you have higher transportation costs, it's also likely to be very, very cost effective. And in fact, here I want to put a word of caution to folks who specialize in comparing cost effectiveness not only across interventions but also across settings. I just want to raise a question. What are the ethics of choosing where to do this program based on relative cost effectiveness when the heterogeneity is driven by the costs? If, as the study suggests, the effects are quite homogeneous and everywhere you're going to see a reduction in child mortality, then in some areas it may be less cost effective than others just because the costs are higher. Let's say, you want to do this in some remote region of the Sahel, it's going to be much more expensive just because getting there is more expensive. Well, does it mean it's not worth it? Does it, de facto saying that the life of a child in the Sahel is less than, to the international community, the life of somebody, in Kenya just because they cannot be reached. Okay, so I just want to, cost effectiveness is very important in many ways, but it's also something to think a little bit about when we're actually looking at the heterogeneity driven by costs and not always by benefits. And in the context where it's extremely cheap in any case, maybe we shouldn't just say this versus that. It should be you're below a threshold that's good enough. Now, given what we just talked about, I think scaling up is clearly needed and doable. So, the news analysis suggests that it is, sufficient to treat water to get effects on child mortality. I want to make the point that even if it's not always sufficient, clean water access is necessary and extremely cheap, okay? And in fact, it's going to become even more necessary over time because of climate change, which is expected to make matters worse. And people, have said that in many areas, increased water temperature and the fact that there'll be more extreme storm events are going to lead to runoffs, into water streams means that drinking water quality is going to get even worse, okay? So treating water is going to become only more important over time. And there are results so far of the number of studies that Steve and Michael shared suggest that embedding delivery of free chlorine for parents of newborns and young children in the existing primary healthcare system, just the way it was done for antimalarial bed nets over the last, in the last 2 decades, is extremely simple. Okay, and that's something that actually we've been thinking about, that we're more than happy to help, governments think about. There's already public primary healthcare systems that are very strong in most countries. They already have procurement systems to deliver essential medicines, to deliver bed nets. Just adding a subsidy for chlorine in the form of coupon or in the form of just directly giving bottles can be, seamlessly done. And so that's something that hopefully, Kenya is going to be, taking the lead on in the coming months, and that other countries can also do. And myself and others who've been thinking about these delivery methods, just including Michael most prominently, are more than happy to be in touch. So do not hesitate to reach out if you're a government official and you want to brainstorm with us on how to do this. We are there. Thank you.
Thanks so much, Pascaline. Great presentation, and also important to put the findings into a bit more context and make the global offer. Just a mere $6 billion to save so many lives. I think, one other thing that I was struck by is, there are these league tables of cost effectiveness of interventions in primary health care, but the costs for this intervention seem to have been reduced over time. So I think that's another good reason this is becoming even more affordable to do under current circumstances. And putting your two comments together, I'm also thinking, you Patrick, you talked about, enabling investments through these other sectors, but this intervention actually could be delivered as a health intervention by the primary healthcare clinic, which I think is what Pascaline is suggesting to us. So it would be kind of on the list of essential medicines and devices that are purchased for a primary healthcare unit, potentially. So that's an interesting point. Now let's go back to, I think, our whole group now to talk. I'll invite Michael and Steve to reflect on the discussant comments, and then we can have a broader conversation.
Well, maybe I'll start. First, I really want to thank both Patrick and Pascaline for these really thoughtful comments. And I would stress how difficult the issues are that Patrick raises in terms of water is not generally considered as part of the Ministry of Health in countries. And so that we in health do think a lot about cost effectiveness and what can we do best. And certainly there have been some very clever distributions through the health system, but there does need to be some cross-ministerial, cross-sector advocacy so that folks who are responsible for delivering water will also think about water quality. There has been a long-standing belief, myth, I would say. There's a long-standing somewhere between belief and myth that water quality doesn't matter, that we just need to think about water quantity. But the data are that water quality do matter, and I'm not sure that that realization has percolated down to government authorities who are responsible for delivering water. So I'm really excited about the government of Kenya's engagement. And I think it's terrific that we're thinking about how to get health more involved. But I also think that the issue you raise about this being cross-sectoral is also really crucial for us to reach all 2 billion people who are currently drinking contaminated water.
Michael?
Well, thank you very much to both Patrick and Pascaline for these great comments. Really appreciate them. And I'm very excited to hear that you feel that this is an opportune time for a policy shift in light of these results. So obviously, that's very exciting, and I hope to come to Kenya soon and would love to follow up and discuss that. And I think in terms of this issue that Steve discussed of the roles, and that Amanda raised of the roles of different ministries, I think there is a tendency for each ministry to do things that are through its own channels, and I think that's, and to the extent that that's a political reality or the way that things will operate, I think that is, if we think about something like dispensers, I understand that's something that might be unusual for a Ministry of Health to support, although personally I think it would be justified. But the coupon program, that is very much working with clinics, and it's very analogous to the larger package of free provision of essential medicines and of things like antimalarial nets. And I think that could be, my personal view would be that could be very easily integrated into what many clinics are doing around the world. And obviously you would have a much better sense of what would be feasible in Kenya, but would love to explore that further. And as mentioned, that's initially was done at a small scale as research. Pascaline's worked in Malawi doing that at larger scale, but would be very excited about a real implementation with working with government systems, and would love to discuss that more.
So we have a question that was from someone I think that you may have interacted with before, who's really king of WASH, really. So Louis Borstein, I know that he's worked with all of you in the past. And he's inviting us to sort of drill down on this question of, this, as Pascaline points out, these are complementary interventions, municipal water facilities connected to the system of pipes versus these other kinds of interventions around water treatment that are direct to households. And they might even work together depending on the quality of water, as you're also pointing out, around the climate change challenge, Pascaline. I guess a question for people to reflect on further, maybe we start with Patrick and Steve, is sort of why do you think this divide exists in the WASH sector? We do spend, the global community spends a lot on WASH as a set of activities. And, how is it that we can sort of integrate the intervention and the systems approaches in a more coherent policy going forward? I mean, we can imagine that there could, I'm not sure because I'm not an expert in this area, but do current policies on WASH take both approaches, or are they really just squarely about systems? So if anyone feels knowledgeable to answer that, I would be interested to know. Patrick?
I
Put you on
think
the
the
spot.
current policies integration would be the best way to go, but that has not been the thinking. And as Stephen mentioned, if you're talking about water, especially for low middle income countries like Kenya, for example, it's not just a question of the quality. Quantity is also of concern to us, because many times you even have municipal water, but the water does not reach your tap. Maybe it comes once in a week. So the quality and the quantity must go together. But again, the other thing that probably had not worked well for us is because we did not have the kind of evidence that we are now sharing today. This is really compelling evidence for us to be able to see. In fact, I'm strongly persuaded that the coupon system should be part of our essential primary healthcare, so that when you go to the primary healthcare clinic, you have an under 5-year-old child in the household. Then this is part of the package that you need to get when you come to the primary healthcare clinic. And not only when you come to the primary healthcare clinic, how do we integrate this with the community health workers, so that you don't even have to go to the clinic, but the community healthcare workers can be able to move from household to household, where the children who are less than 5 years old, and they can be able to distribute the water treatment chemical, the water guard that Michael and Stephen shared with us. I think that would be, I'm strongly persuaded that based on this evidence provided here today, we can quickly be able to have a policy shift as we scale up universal health coverage through the primary healthcare approach, based on the science and the evidence that these are shown us. Even if you look at like the recently launched malaria vaccine, again, that showed an efficacy of 30 to 40%, equivalent to what you are demonstrating here. And therefore that one, WHO has advised that we can be able to scale it up. So this is also another intervention where we have science to be able to prove it, that we can be able to take it going forward as part of essential primary health care program, supported by strong community health workers and a strong primary health care approach. Thank you.
Thanks.
Yeah,
Steve?
I'd like to add. First, Louis, thanks a lot for the question. I think one of the reasons why this is hard is it's actually kind of weird and counterintuitive. And Pascaline pointed this out. There's all sorts of fecal contamination in the environment. How is it that if we just reduce it from water, we see such a big impact? And by contrast, why, when we do randomized controlled trials of sanitation, do we not usually see an impact? So this is just all kind of weird. And so I think that what we've allowed is this belief that everything matters, and let's try to do everything, and let's try to do integrated interventions be the ethos by which we go forward, rather than being driven by evidence. I suspect that there's something about the water pathway, something about that being important, being biologically available, that water maybe being also being used in food preparation where the pathogens could grow. I'm not real sure why, but I think there's something special about water. And I think that we are really called on to follow the evidence here. And the evidence is that water treatment saves lives. And part of the tension here too is that WASH is both a health agenda and it's also a human rights agenda. And so that if we think about a right to sanitation, the WHO has endorsed a right to sanitation, and that can be very important for privacy and dignity, and those can be really important interventions along that realm. But if we think about what are cost-effective health interventions, the data suggests that water is different from these others. And I think that we need to, I'm actually really excited that Patrick says, look, this looks like really compelling evidence. And I agree that I think that this should encourage us to change the conversation, to say there is something that is particularly special about the value of providing households with enough clean water so that their children don't get sick.
Thanks, Steve. We've gotten another question, and maybe I'll go back to Pascaline because you've raised this issue, and you were also talking about it, Steve. You know, the recent work looking at those other pathways around hand-to-mouth contact, soil ingestion, contaminated foods. they suggested, I guess, in their work that these were larger contributors to fecal ingestion than water, and yet we see the findings from this meta-analysis. So I don't know, Pascaline, if you want to sort of reflect on that point again that you've made, or the previous question, if you have thoughts.
I think Steve, said it very well. It's going in. The people had very many reasons to think that there would be a lot of pathways that would need to be thought about at the same time, and complementarity was a very likely hypothesis. And I think it's in some I think it's very good news that you can actually make a big difference, just with the water pathway. I think it's excellent news because it's often going to be much easier to work on the water pathway on its own than through everything else. So yeah. It's just like it's the type of amazing result that's like, it's like what's easier to do is actually effective already on its own. So that's great. It doesn't mean that we necessarily have a very good understanding yet as to why, but I don't think it's necessary to fully understand why to go full steam ahead because lives are on the line.
Can I invite all of you to reflect on, okay, given this new kind of evidence, how would you hope to see WASH policies change, the WASH policies of the World Bank or of the WHO for that matter? You've mentioned that they have a particular emphasis on different pieces and that they have other benefits, but what exactly would you like to see sort of change in terms of how policies are developed or how money is used in this space?
So I think it would be useful for the health bodies to once they if they feel similarly as we've heard from the Kenyan government to start treating this just like other essential preventative goods that are inexpensive and where we know that take up or usage depends a lot on free provision, and to start providing them for free. And that so I would say that the number one policy implication of this is for health ministries to start doing that, or international health bodies to start exploring those. But I think there are implications beyond that as well. So for the authorities that are in charge of municipal chlorination systems, there are things that could be done to try to make sure that water is actually treated, and to make sure that there aren't negative pressure situations. And I'm not an engineer, but there aren't negative pressure situations in the pipes that allow contaminants to get in, which then react with the chlorine and prevent the chlorine from doing its work of reacting with fecal material or germs in fecal material to kill them. So I think probably some more investment both in making sure that the chlorination is reliably delivered and that it reaches the intended users is probably warranted. It may also make sense to think about, I agree with Steve that there's been a lot of emphasis on water quantity, and quantity is very important for other reasons. But I think sometimes I'll go even broader than WASH. If I think about water more generally, people sometimes treat water as a unified sector. And I think that can be very problematic. Take the issue of water pricing. I'm for industrial and agricultural use of water, as we see in the United States and California, for example. I think most economists are quite sympathetic to water pricing to avoid wastage of it. I myself am pretty sympathetic to it. That's, or if we're thinking about even supply of water, even in a low income context, there are some sizable costs of putting the infrastructure in place and maintaining it. Now that may be a very worthwhile investment, but it is more costly. Just treating water to make sure that existing water is safe, that's incredibly inexpensive. And we know, but the willingness of consumers to pay, consumers can see whether they have water or not. It's very inconvenient to have to go walk half an hour to go get water. They will consumers will pay something to get the water delivered to them. So that you may be able to charge for. But water quality, it's hard to, A, it's hard to charge for that. It's not so visible. B, it's minuscule amounts. So the amount you would collect, you spend collecting it is most of the money would have to go to the collection system rather than to actually paying, in a bottle of WaterGuard, the dilute chlorine solution, the packaging costs more than the chlorine in that bottle of WaterGuard. So at least to the packaging and the marketing and so on. So I think for water treatment, that's something that not only health ministries but other ministries could be involved in. But for the clinics, making this available for free at the clinics, that seems a natural role for health ministries, for example, through a coupon system.
I just want to add one more policy recommendation, and that is that I think that water utilities should report water quality at homes rather than water quality as it exits the plant. So the current standard is that you test water quality as it exits the plant. Well, that's usually fine. But then you put it into a water distribution system, which the water utility is also responsible for, and it has all of these cross connections and all of these breaks and all this, and so you come out with highly contaminated water. And but the water utility system isn't held publicly accountable for that because they say my utility is doing fine. So my policy change would be you have to randomly draw from consumers, get that water coming out of the pipe, and that's what you report. And ultimately, we have to then hold utilities responsible, not only for what's coming out of the plant, but for the distribution system as well.
Yeah, and I mean, the regulators don't necessarily follow up on this agenda either, whether it's on the public health side or the water utility side. So that's a great point. So we have another comment from Tanvi Nagpal, echoing Lewis's concerns. She says, there's a difference in the nature of the service delivered at the health clinic versus at the utility. The former provides a service that is consumed on site and can be observed. And on the other hand, the level of the utility's service delivery chain is long, difficult to observe. So it's essential to have these conversations too, because health donors are less likely to understand or support a much more difficult to monitor service. So I wonder if she's suggesting that the enthusiasm about supporting something that can be delivered alongside primary health care, although difficult to observe its use and less following up. But anyhow, it's no health person is going to put money necessarily into a water utility. Probably not. They would leave that to the water people. But maybe if others want to reflect on that point.
And one thing that this is partly following up on your point, partly following up on Steve, from a research perspective, but I think also from a monitoring and policy perspective, the one wonderful thing about chlorination is very easy to test. You just take a sample of water and you see whether and you can very cheaply with just a very inexpensive strip, test it to see whether there's chlorine in it. So now that I totally agree with the broader point. It's important to test this, but that actually is feasible with some expenses for surveying. But we should be doing that much more broadly, not for fancy research purposes, but for basic evaluation and monitoring purposes. Any funder should be asking for that, whether it's a government or a donor, to make sure that this is actually, getting through to the people it's supposed to serve.
I think that would be very, very important for situations like in low middle income countries where, apart from the municipal water connection, of course, we also have what we call illegal connections, especially in the urban informal settlements, where because people may not be able to afford the cost of municipal water, then they go ahead to drill holes in the pipes and make illegal connections. And next time, Professor Michael, you in Nairobi, will go with you to Kibera to see the reality on the ground. And all those pipes are exposed, there are leakages everywhere. For sure, those are likely to be contaminated sources of water. And if you can be able to have a strip that you can be able to use at home quickly to be able to identify whether the water has enough chlorine or not, would be a very, very big plus, so that at home, then you can be able to tell, oh, this does not look good for me to be able to consume.
Wonderful.
Thank you.
That's a great idea. And, just being more conscious of it, getting people to test is a great way to collect information too. Okay, well, I think I've had my questions answered. I'm very clear on where to go from here. Any last thoughts or reflections based on this conversation? It does seem like such a marginal investment for such a big impact. I actually was thinking, in the initial phase of the COVID-19 response, when people thought it was, transmitted by hand, contact and access to water. And, so much money has been mobilized for this response, and you would have hoped to see some part of that go for, say, for water as part of the initiative. But do people have thoughts on what can we do now? There is still lots of COVID-19 response money around. Is this part of that agenda?
We should invest that money in the water sector, because we have seen, especially in low middle income countries, because of availability of water for hand washing, the number of cases of diarrheal diseases have really gone down during this pandemic. And of course, that is anecdotal, but now based on this study that has come up, if we can be able to invest that money, then we can be able to make a whole lot of difference in the lives of children, especially under 5 years of age. Will significantly reduce the mortality. So if we can be able to channel that, because now we have sufficient quantities of vaccines, and of course we also have a lot of problems with the vaccine hesitancy, then we should also be able to channel part of that water towards this worthy cause.
Yeah, excess deaths have many causes, so that's a good point. Last thoughts before we wrap up? Okay, well, I've found this to be very compelling. I think it's really updated my priors on the cost effectiveness of water treatment versus other kinds of primary healthcare interventions. And I really like the idea of having it be part of a standard package of clinical care, like a bed net. And I hope that we follow up on all of these ideas. There's a number of organizations that work in this space that are really ready to work with governments to build this up further, including Evidence Action and others. I don't know, maybe Steve, if you could reflect on what are the different organizations that work in this space that you think are useful to support?
Well, I think Evidence Action is really important because they're really out there working in rural areas more broadly. I do think that I'm really persuaded by Pascaline's work on the use of coupons. I think that this suggests a really efficient way for us to include this in the health sector. I think that it's just harder for us to engage the water sector, and most of the money, the vast majority of money that goes into public water supplies is government money. This is not primarily supported by donors. And so I think that I think that we researchers need to spend more time with colleagues who are working in this place, working in that space, and thinking about the incentives and disincentives they face, and how we can work within these institutions to help improve performance. And so I think that's an area of, I know that we want everything to just be the one plutocrat who's going to give $6 billion and save 3 million lives, and I'm all for it. I'm totally.
I love plutocrats. Yeah. Okay.
Yeah. I mean, this is fine. But I also think that we really need to work with our partners in government services, and those issues also involve thinking a lot about what incentives are at play, and what where there might be some leverage so that we can improve outcomes.
Absolutely. And again, as part of a holistic strategy that includes the infrastructure needed to bring safe water to households on a permanent basis. But in the meantime, these inexpensive interventions. So thank you so much to our panelists for a great session. We'll post the link to the paper when it goes up next week, maybe. You'll let us know. And thanks to the audience for tuning in. We really appreciate it.